Hello, and welcome to the webinar on benefit package design for universal health coverage. This webinar is organized by the German Development Corporation through the program Global Alliances for Social Protection, which is implemented by GIZ. I think we can go ahead with the slides. Click, please. Yes, one more. So I'm Victoria Rabowskaya, and I'm a regional coordinator for Asia at the Global Alliances for Social Protection program. I'm based in our regional office in Jakarta, Indonesia, and I will be your host for today. Our speaker today, next slide, please. Our speaker today is Ioana Ursu. Hi, Ioana, welcome.
Hello.
Hi. So Ioana is a pharmacist by background and the former Secretary of State of the Romanian Ministry of Health. She's a senior health system consultant with over 10 years of experience and a specific focus on pharmaceutical policies and benefit package design. In her role as a Secretary of State, she was in charge of the national pharmaceutical policies and pharmaceutical sector development, all the way from regulatory aspects to health technology assessments, HTAs, and also reimbursement negotiations on national level. In her extensive consultancy work, Ioana worked on mapping health systems and advising sector stakeholders globally. By now, she has covered 78 countries across Europe, Africa, Asia, and Latin America. And recent projects of her included the Philippines, Togo, and Indonesia. Once again, welcome, and we are looking forward to your insights.
Thank you for having me here.
Hi. Right, let me take you through the agenda for today, briefly. So, firstly, one more slide, please, to the agenda. Thank you. So firstly, I will give some more background information on this event, the context and the rationale behind it, before Ioana will take over and present the PROMISE systematic framework, which was developed by her based on her international work. Please note, we will have a short Q&A break after the first part of the presentation. So please post your questions right from the start, because we will take some of them quite early on. Also, we have quite a number of participants registered and joining us, so which is wonderful. So please, however, bear with us if we cannot address all the questions due to limited time that we have. We will try to address the question later on, and I will provide some information on that. So after the second part of the presentation on the framework, we will have another round of Q&A and an open floor discussion. So again, please do post your questions as they pop up so we can collect them as we go and then post them in the end to Ioana in our discussion. Finally, we will have a wrap-up in the end where we'll address next steps and what can be expected from here. All right, so just to give you some context, next slide, please. Thank you. To give you some context on the event today, what we do at the Global Alliances for Social Protection program, where I work, we address emerging and other interested countries which are undergoing major social protection reforms. So as we see patterns of reforms globally, the idea is to create peer-to-peer networks and connections for exchange among those peers. So challenges from the field can be jointly discussed and respective solutions developed and shared. As such, we have multiple working streams on a variety of topics in the social protection field. And now one of the burning issues we identified recently in social health protection specifically is, and you might guess it now, is benefit package design. So this is why we set up this webinar. Next slide, please. So the overall objective, the midterm objective here, would be to provide the opportunity to policymakers and practitioners to connect and to share their experiences on this topic, and basically to discuss challenges, solutions, and additional best practices as they evolve. For today, specifically, this first kickoff event, the goal is actually to create some common ground for the exchange. And secondly, to actually verify and really see the respective demand and interest from the audience. So based on the feedback today, we will see how to move ahead. This is why I would really ask you to support us by filling out the short questionnaire, which you will receive in the end, because it will help us to see your real priorities and wishes for the future. So we can go from there and address the demands and preferences respectively. Okay, so this is a little bit on the background, and now let's move to the actual issue. Next slide, please. So why the focus on benefits and benefit package design? Well, as probably most of you who participate in this event know, in recent years we see more and more countries engaging in reforms, moving their healthcare systems towards universal healthcare coverage. So to achieve this, countries can modify the various health financing functions, namely resource collection, resource pooling, as well as purchasing of services, to provide better coverage for their population with the services, and to ultimately provide better financial protection for their population. Next slide, please. Can we go to the next slide, please? Thanks. In theory, our healthcare spending, which is nicely organized now, would go to 4 major categories. We would have services, which are mainly made up of HR costs. Should be the major cost block in a healthcare system. So once we paid our doctors and nurses, this should take up about 40 to 60% of total healthcare expenditure. The second largest item is medicines, which ideally should take about 20 to 35% of total healthcare expenditure. And further budget items can be allocated to public health or specific vertical programs. And then we have various infrastructure and admin costs. However, what happens in practice is that in majority of systems that we are looking at is the following. Basically, A, the HR share tends to be lower due to low levels of salaries. And B, medicines therefore take up a far larger share. So this means that public health expenditure is still often complemented by out-of-pocket spending, which is mostly directed at paying for medicines. And this is usually due to the fact that the public UHC-directed system is actually unable to fund medicines appropriately. So it implicitly pushes those costs back to the private pocket of the patients. Click, please. There we see the parallel financial flow, which is mostly directed at medicines, as we see from empirical evidence. So next slide, please. To give you some more arguments and figures on this matter, efficiency, effectiveness of coverage, and the financial sustainability of national funds. So looking at those aspects, if we go back to the famous WHO report of 2010, we can see that medicines and related systematic issues account for the top 3 system inefficiencies. Click, please. And one more click. In terms of coverage effectiveness, as I mentioned on the previous slide, most of out-of-pocket expenditure, namely about half of the total private spendings, are spent on medicines, as you can see from this graph. One more click, please. Thank you. One more click. And finally, we will also see here how expenses for medicines hit on poorer countries' budgets specifically, as they can take up, one more click, please. Yeah, and one more. One more. And one more. Thank you. So here we can see the share of medicines taking up from the total health expenditure, and specifically the share can go up to 70% in poorer countries. So, which you can see in the bottom corner on the right. So looking at those numbers and thinking and considering ways to find better coverage in terms of access and financial protection under and not outside of the package provided by the national healthcare system, but also efficiency and financial sustainability of national funds, we will see that there should be some effort to actively manage the benefit package in a systematic manner. So with that reasoning, I would now like to ask Joanna to provide some suggestions on how to do that and present her framework to us. The floor is yours. Hi.
Hello. Click, please. So over the next few slides, you're going to hear me saying click a lot. I apologize. It's because I do have a lot of animations. I was trying to keep less slides, but unfortunately more dense as a result. So to pick it up a bit from where Victoria left it, so what do? Let's assume you have recently introduced universal healthcare coverage, or less recently, let's say in the past 20 to 30 years. And you are starting to see that the block of medicines, the second pillar, is starting to take actually more than 50% of your expenses. If it's not taking 50% of your expenses, you're starting to see higher co-payments, or you're starting to see bigger out-of-pocket payments, or from the get-go, as you are just setting up now the system, you're thinking, so how do I tackle this? What we are trying to say, what happened in many of the countries is that when they are discussing this, or the latest trend for the past 10 years has been to assume that the cost, apologies, the light went off. We have to say it. So what happens in most of the countries is that we have seen that the countries are just assuming it's a question of implementing a new tool, a new intervention, and specifically the latest intervention that I'm hearing about a lot tends to be the health technology assessment. What we are saying today is that health technology assessment, pricing, regulatory aspects, all of it are actually part of a bigger framework. Solving the issue of the cost related to medicines may not be just a question of putting in place the health technology assessment. It might be just a question of maybe something else. Maybe we need to look at regulatory prices. Maybe we need to look at the prescriber behaviors. Maybe we need to do something else. But which one of the ones do I need to apply in my country? And how do I fit them all in? And this is what we're trying to do actually today. We're trying to look at how we can evaluate our own system based on a more general pattern. How do I identify where are my potential gaps? And where do I have actually a duplication of effort? So when we are looking at evaluating the system, we propose 3 approaches, or 3 layers rather than 3 approaches. Click, please. So the first aspect in any kind of pharmaceutical decision making is looking at my system and deciding if I have the mandatory functions. We are going to discuss in a second what those functions are, but the first thing you're going to look is, do we have the functions? Do we have the framework? Do we have the cadre in French? Click, please. Then we're going to look how the flow of information happens between these functions. Is it continuous? Is it coherent? Does it make sense? Or actually, do I have, like I said, some duplication or some gap or some gaps in information that is moved from one function to the other? And then click. And last but not least, we're going to look in between these functions and within the functions, actually, what is it doing? And this is where actually the tools and the interventions that I've just mentioned earlier, the HTA, the pricing, the supply chain, all of them actually fit here. They're a tool, they're an intervention. So we need to see how that intervention would fit into my overall framework. Click, please. What's important to say about this particular approach that we are having is that we are not saying that it's not space for a lot more. Actually, or the opposite. What we are saying is that in today's world, when we actually are starting to have quite a bit of data, we can have a decision driven by actual data, by evidence, rather than by hearsay. So we are finally in a position where we can make decisions related to medicines based on evidence, both based on clinical evidence, but as we are going to see, based on what's actually happening in our own countries, in our own systems. Click, please. So what are the functions of a pharmaceutical system? Especially we're here going to refer to the reimbursement one, or the coverage one, but it can apply to the overall system for those countries or for those of you who still have mainly the vertical programs. Click, please. So the main thing that most of the countries should have in place by now is the regulatory function. It's what we all know as the Food Drugs Administration, or EMA if you're in one of the European countries, or WHOPQ if you're more in the African continent and you're relying on the WHO to do the evaluation. What do these agencies do? Their main role is to assess the safety of the product. They're also looking at granting marketing authorization overall, and they're generally focusing on ensuring that there is a quality in place, quality checks in place, and a process to make sure that the drugs that come into the market are safe to be used, but also not counterfeit, and we have a continuous flow of quality drugs. So up till now, I think all of us can pinpoint already this function being ticked in most of our countries. Click, please. The second function that most of our countries tend to have, whether we are looking more at countries that are just starting the universal health coverage or very much developed, tends to be the clinical review. The clinical review, it tends to be, it's normally formed by clinical specialists, pharmacists, medical doctors. It's our key opinion leaders, how we call them. It's the big professors in many cases. They will decide if the drug is effective. And the way they do that is by looking if the specific product that comes into the market adds anything or is equal to something that I'm already using. Fortunately, we are in the 21st century. We rarely have diseases that don't really have a treatment, except for the, of course, the neglected one and the orphan ones. But generally, for the 90% of the 95% of the diseases out there, we do have some medicine already in place. So when a new medicine comes in, our question will be, is it the same as what I'm already using? Is it offering the same value? Is it better? Is it worse? And then based on that, ideally this group should be deciding and saying, okay, it is good, it's worth having it, and we can use it first line, second line, third line, and therefore we are likely estimating that the volume of patients that are likely to benefit in my country is this. Click, please. The third function, and this is the one that is less developed around the world, though it's picking up quite fast, is the pharmacoeconomics function. In some countries, it's actually it's also called health technology assessment function, but that in most of the cases, it kind of incorporates both function 2 and 3. We'll come back on that. But overall, this function, the economic function, will establish the correlation between the clinical value that was established by the previous function and the volume of patients and the price. This function tends to use things like local affordability levels. They will use international references many times. This is the unit that will always bring in the discussion of how am I going to correlate the volume to the price and the price to the volume. It can use various tools like cost effectiveness analysis if you're looking at countries like Australia, the UK, Sweden. They're also going to look at cost benefit analysis, which tends to be more the Germany and France. You're also going to look at, and not the list, by the way, Philippines, we're working with them quite a bit these days. And also, if not, or after all of this is done, there's also going to be the budget impact assessment. And again, this will be that function. I'm sure that already if you think in your systems, you can pinpoint, if not a team, maybe an institution or someone that does this already, or incipiently they're starting to do it. Click, please. Then first, or the big function that tends to be most seen around the world, and the one that has the biggest public visibility, tends to be the team that does the pricing negotiations. For those countries that have pricing negotiations, the pressure is huge, and this is the team that generally says, yes, this drug at this price can be reimbursed. Even if it's not a face-to-face pricing negotiation, it can still be a situation of submitting a dossier with certain data and the final decision being done based on what all the other elements presented, clinical, economic. This will be, like I said, this tends to be a function that is very politically sensitive. It tends to be the one where actually even politically there's going to be a lot of influence, as you can imagine. It also, most of the times, you're going to see ministers involved at this point. Click, please. Once the price is set, once we're saying, okay, this goes into the package, normally another function comes in and does a bit more of the administrative part, which is the one where it says, okay, this is the overall price, kind of estimated volume. I can actually forecast based on my data and based on my consumption how much I'm going to use over the next 2 years, and I'm going to issue a tender. And this is the function. This is the function in some of the countries that are just now starting to move towards universal health coverage. This is your function, the one that does the procurement for the vertical programs. In the countries that have already implemented a health fund system, a health insurance system, this is the function that is fulfilled by the health insurance fund, the one where they are starting to look and make sure that the budget is respected, that the prescribers know exactly for which patients they need to prescribe it, that they also understand exactly in which situations a drug needs to be procured, and also they know exactly how to procure it, so they will do the tendering, and they will try as much as possible to lower the cost by ensuring and guaranteeing a volume. Click, please. The last function of a pharmaceutical system is actually the monitoring function. It tends to be a bit of a newer one. And like I said, it has to do with the fact that for the past 10 years, we're starting to have more and more access to data and capacity to monitor what's happening to the product in the system. This function normally is formed of one unit or several, which are in charge of monitoring the expenditure, monitoring the drug usage, and monitoring the drug prescribing. Again, this is more of an ideal situation. So if that's assuming that this function is there, and assuming that they are able to collect the data, and assuming they have the capacity to understand what's happening in the real world, this function should, however, present afterwards policy solutions. So they should be able to provide to all the previous functions things like statistical data, actual consumption data, actual results data. They should be able to dynamically, as required and on their own initiative, be able to provide feedback to the other functions, so all the systems know, so the system overall knows what's happening in the system. Click, please. So I'm sure it was a lot of data, and all of us are still kind of grappling with it. And some of you have managed to follow me. We will go through this as we speak. One of the things that I want to say is that while the functions are the same, so we have seen the functions, the number of institutions fulfilling those functions can vary per country. And the reason for which I say that is because in many countries, the moment we're starting like I said, we're looking at the benefit package or even putting in place a new unit like the health technology assessment unit, we're seeing a bit of a power struggle with people trying to wondering how is it going to fit in, but also potentially who fits in the role, how are we going to do this, etc. What we are trying to say today is that rather than losing a bit of time, but also highly skilled people, because unfortunately we are, egos come in. Rather than doing that, what we should focus is in making sure that we build on the institutions that we have already. We just make sure that the functions are present. And to give you an example, we're going to use, the first example is actually France. Click please all the way so that it fills the whole row. Click, click, click. Yeah, so this is France, for example. In France is a more of a characteristic, more kind of like easy to read system because it has more of an institution almost per each function. So you can see that they have the NSM for regulatory, that they have the scientific, the clinical review team, the transparency committee, which makes the clinical review based on additional benefit. Then there's the pharmacoeconomics team, which will look at specifically the clinical impact, the economic impact. And once they give the go-ahead, there is a pricing committee which sits between Ministry of Health and Ministry of Finance and makes a final pricing decision. And then it decides if it fits under the tariff or it's above the tariff. For the French out there, this will make sense. Once that decision is done, the actual purchasing and actual negotiations based on volumes are actually, and controlling the provider comes down to UNCAM, which is the National Health Insurance Fund. And then it's the same, this fund then reviews specifically what's happening in the hospitals. I'm saying what's happening in the hospitals because we're going to discuss this in a second, and you're going to see that no one yet manages to do a full comprehensive monitoring function. Next, please. And again, please fill the row, click, I think it's, yeah. So in the US, sorry, not in the US, in Russia, as you can see, or for those of you who may know this or don't know this, from 2013, Russia has engaged in a quite high reform, big reform of the pharmaceutical system because they were trying to enlarge their coverage. So right now, all the 4 functions are actually fulfilled by mainly 3 divisions in the Russian Federal Ministry. The regulatory, the clinical review, and the essential medicines pricing. The economic evaluation and the pricing function are pretty much fulfilled by the essential medicines pricing division. Once that decision is done, the decision is done for the whole of the country. And that product then needs to be covered for all 80 regions. Then there are 81 regions, 80 plus Moscow, regional ministries of health, which will then be in charge of issuing the tenders and making sure that the prescribers know in which situations a drug needs to be used, and then they will also monitor what's happening in the actual country. Then they will feed back that result back to the federal ministry. So up till now, it was clear. Up till now, it seems quite clear. Okay, so these are countries, we're looking mainly at single payers, etc. Does this apply to a country that has multiple payers? So let's look at the US. Click and click, please. And another, yeah. So in the US, all of us know about the FDA. The FDA will grant and will say a drug is safe. And once that is present, then the product is freely available on the market. Then the 500 or so insurance plans will each of them decide on whether that new product should be covered or not. What most of you potentially don't know is that actually all of the functions mentioned earlier are present in a mini version in all of this, or in the majority of the health insurance plans. So all of them will have a medical director, which tends to look actually exactly at that clinical part. They will also have a pharmacy director who tends to look at drugs specifically for the ambulatory setting, but again at the clinical part. They will have an actuarial division who will look at the pharmacoeconomics and the pricing of it. And then they will have a team that does negotiations based on the overall portfolio. They will have the tiers, then they will issue step edits, they will say prior authorization, they will give specific conditions in which a product can be covered, and then they will monitor what their physicians and what their pharmacists, the ones with which they have contract with, what is it that they're doing. So as you can see, these functions apply actually to different settings, whether you have a single payer or a multiple payer situation. Some questions up till now.
Yeah. So thank you so much, Ioana. Thank you for this first part of the presentation, showing us the main, or the 6 defined functions, as you call them, which should be present in any system aiming at UHC. So I think we have a couple of questions from the audience, but let me just first use my role here and ask you, so you presented now the examples applied to quite sophisticated systems and quite advanced countries. Would you say that the same framework in terms of the defined functions, as you showed them, would it also be possible, or does it apply to countries which are a little bit further behind, or which are just, from a socio-economic perspective, poorer?
Thank you. Thank you for the question. And actually that fits into the presentation. Next slide, please. So I'm actually taking the opportunity to say hello to my Filipino team. And by my, I say it's the team from the Ministry of Health in the Philippines. So not in many of the countries that I'm working for the past few years, we're not looking actually at very developed systems. We are looking at what is it that they already have, and how can we actually create this flow, and how can we actually create all of these functions. So, but like with everything else, the first thing that one needs to do is to evaluate to see exactly where they are. So let's look at Philippines. Click please all the way through. So Philippines, if we're looking at the first function, Philippines does have already a Food and Drug Administration, which is already in place and it's working, and currently they're moving the standards up to the ASEAN level. So pretty much it's there. Then they have a formulary evaluation committee, which does the clinical review, and they've been having this for the past 10 years. So from that perspective, whatever we are doing from this point on is building one on this particular function that they have already, because it's there and it's already, the skill is already there. What they are missing is actually the pharmacoeconomic unit, which we are now building, the HTA unit, and we are trying to bring together the functions 2 and 3. The big issue comes when we are looking at the pricing capacity, so the capacity to establish a price. What we are seeing is that the PhilHealth, which is the national health insurer, the public health sector, which covers about 10% of the population, they do have one benefit design team, which is more used to this and is more used to using this type of data and building a package. But they are very small and it's only for the health insurance, but we have it already and we can build on it. But an overall pricing unit within the Ministry of Health is actually missing. So what we know is that we are trying now to kind of bring in the design team into the pricing unit team in order to make sure that we don't create a parallel system. So we're bringing it in so that we create something, but right now it's not there, so we need it. Then what we are seeing is actually also in terms of the purchasing capacity or the decisions regarding the prescribing, we see actually a parallel system formed already. So we have the vertical programs on one hand, which have not yet fully been integrated into the health insurance, making their own decisions about how, for example, a TB drug should be reimbursed or should be covered and in what conditions. And then I'm having PhilHealth, which for separate packages make their own decision. Right now, they don't overlap too much, so it's good. But we do have, for example, antibiotics that are used in TB, and we do have patients that are covered by PhilHealth, which will have a TB diagnosis, and then they're actually covered, they end up being covered by PhilHealth rather than by the vertical program. So we do already see a duplication of effort there, but also inefficiencies in the system, because I'm not sure at which price the product is going to be. Is it going to be at the level established by the vertical program, or is it going to be at the level at the overall market level, but just being reimbursed by PhilHealth? And then in terms of the monitoring function, what we are seeing is that there's only the monitoring currently only happens for 10 packages. And I actually have had the question, is the health information system a prerequisite for monitoring?
Exactly,
No.
you could see it right in the chat. So
and
this is just
I recognize it, yeah, and it's a common problem actually in countries which are just picking it up, the universal health coverage. No, sometimes what we can do is, or what is the basic recommendation from the WHO, and we know it works, is that we establish at least some indicators. You know, we take specific diseases with specific drugs, and then we monitor what's happening with them over the next 3 to 6 months, up to a year, and then we feed them back. And then the way we pick those diseases is actually based on the burden of disease of my own country, where I'm trying to understand what's happening. So you can do it pen and paper, you can do it Excel-like. What's important is that people get into the habit of filling it in and then sending it back to the center. And I'm sure that the M&E people that are on the call can speak a lot about the flaws. Of course, ideally, on the long term, what we need is big data. If we want big data, we need an information system. But that's kind of like the ideal. And if we can't have the ideal, we can come up with something that works.
So at least correlating the burden of disease epidemiological data and the utilization packages would already help somewhat. And then whether we can do monitoring on the individual utilization level or not, this keeps to be to build up. Okay, exactly. Looking at the time, we do need to hurry up a little bit.
Sorry. I'll very quickly,
yeah.
If you press the click just all the way through, please. So very quickly, I just want to highlight, or I just given an example of a country that we've just started working with, which is Togo. And where you see the exclamation point, it's where you see the gaps. Clearly, this is a country which is just starting to make the decisions. You can see that the economic decision, the economic input is missing, therefore the pricing input is missing. What we are seeing realistically is that 70% of the health fund currently is being used by medicines, and we can easily pinpoint it to the lack of those functions. Click, please. Yes, Victoria.
Can we just, so there was a second question in the audience coming from Marta, which was saying, how would Ministry of Finance support pricing policy in a country? And I guess you could actually go back to your statement that you can have the functions in the system, so that would be the pricing one, and then actually various institutions which can be involved in it. So am I on the right track here? Do I get it correctly?
So in many of the countries, actually, the economists are not in the Ministry of Health. They tend to be over at the Ministry of Finance. So that capacity of bringing in things like budget impact forecasts, but then even the pricing negotiations, you are more likely to have people that have that capacity and that knowledge within the Ministry of Finance rather than in the Ministry of Health. What's important is that we bring them together. So either you create a unit that is across the two ministries. In my experience in Romania, if you do that, no one responds for that unit. So I would recommend that it sits under one ministry. But even if you do have it in between, the idea is that it's more about bringing in the knowledge that you already have in the country and building on what you already have. So that's where I think the Ministry of Finance can support. Of course, they can also support by always allowing more money for the health system, but that's a different story.
Right. Thank you. Okay, so I would suggest we move on to the second part, and I leave you to it, and we'll have the second round of discussion after the second part of the presentation.
Thank you. So I'm aware of the time. And again, what's important, once you have the functions, once you have identified who does what, once you have identified what's happening with them, what's really important is that not just that the functions are present, but that they work like a team. or put it more nicely, to work like a river, to have a flow. Or what I like is the idea of a snowball effect. I'm sorry, but my graphic designer was not able to come up with my snowball effect, so he came up with a river. So what's the idea? If you're looking at the clinical and economic data that is submitted by the manufacturer, which is like the initial clinical trial, what they're coming up with, they submit that data to the regulatory function. The regulatory function will look and assess, and we're going to discuss about what they're assessing, but they will assess and then create kind of like a snowball of information. That snowball of information, exactly as it is, it should go directly into the clinical committee, because the regulatory and actually the clinical committee tend to speak the same language, which is more the medical one. This clinical committee would then add their own layer of information. They would look at the effectiveness, they would look at their own guidelines, and then create a bigger snowball, which would then go to the pharmacoeconomics team. The pharmacoeconomics team will add the layer related to budget impact, cost effectiveness analysis if you're using that, cost benefit, any kind of assessment of how does it mean, can I limit it to a certain population, etc. And all of that will come into a bigger snowball, which then, with that information and that dense of an information, you can make a proper decision about pricing, and a price that is relevant for my system, a price that is relevant for my affordability levels. And if I've managed to reach an agreement on the price with the manufacturer, only at this point do I make the actual reimbursement decision. If I grant the reimbursement decision earlier, which is what happens in many countries, that the reimbursement decision is taken by the clinical team rather than by the pricing team, what happens is that you lose your capacity to negotiate the price, of course, because the decision was done earlier on. So it's really important that it's only at this point that you're saying, okay, once I've agreed on the volume, once I've agreed on the price, and once I've agreed on the value of this and in where it sits in the population, only then do I grant it access to my reimbursement list. Once that happens, then the health fund comes in and says, okay, you have access, but this is my expected volume over the next year. I can only take up to this much. I'm going to prioritize X, Y, and Z. I'm going to therefore put guidelines in place exactly to what the clinical review team has said before. And then all of that information finally goes into the monitoring function, which will then start monitoring what's happening in the market. Have I used as many patients as I thought I was going to use? Have I have enough competitors in the market if I'm looking at generics? Are the physicians prescribing like I said that they should be prescribing? All of that information needs to be fed back afterwards into all the other functions, like I said. But it's very important that it is this flow of information rather than various disparate functions making decisions. So many times, for example, I'm seeing monitoring being done based on the clinical review team or based on guidelines which have been given by the second function. And I'm like, no, they should be monitoring what the health fund needs rather than what the clinical review team needs. So it's all of these things that maybe you need to have a look how they interact with each other. Okay, so how should they interact with each other and what is it exactly that each of them are looking at? I'm sorry, the next slide, just to let you know, it's dense. So I'll try to make it as nice and edible as possible. Moving on. Click, please. So like I said, for efficiency reasons, each function should be using the data that has already been given by the previous function, or if they are the first function, they should be generating the data in a form that makes sense to the following function. So let's start with the beginning. Let's start with the regulatory team. Click, please. So what does the regulatory team normally look at? And by the way, this is pretty much standard around the world. Like I said, this function tends to it's pretty well developed around the world. So generally, this team will be looking at product efficacy and safety in terms of trials. They are going to look if the trial comparator is there, but most of the times they accept placebo. And they're going to look at the quality of production. They are also going to look at the epidemiology of the country and say, okay, do I even have this disease? And then they're also going to say, okay, if I have this disease, how many patients roughly do I have? So the incidence and prevalence data. To make it a bit more easier, I'm just going to build on the idea of one diabetes product. So let's say we have an oral diabetes product, which is for type 2 diabetes. Most of us are starting to have a problem with this disease, right? So a new product comes in. The first thing I'm going to ask, do I have the disease in my country? Yes, I have it. Roughly how many patients do I have per year? This many. I'm going to look then and say, okay, is this trial done in international settings? Will this apply to my country? Yes. The quality of production, those are all very specific skills. What I'm going to give afterwards, in an ideal situation, I'm going to grant the marketing authorization, but then what I'm also going to do is for the next function, I'm going to create a nice dossier in which I'm going to tell them this is the product indication, this is what I estimate would be the population, the prevalence and incidence in my country. I'm also going to say this is the product safety. So right now it's safe to use in all of these people, but also you should be aware that this is the trial data and specifically the efficacy data that I was granted access to up to this point. Click, please. So at this point, the clinical committee will take all of that, and then they're going to add a bit more data. They're going to say, okay, if this is diabetes, I am currently treating it with metformin. It's the basic WHO recommended oral product. Is metformin working in all of my diabetes patients? No, it kind of works in 60% of my patients. So if that was, let's say it was 100,000 patients that have diabetes in my country, I'm going to assume that about 40,000 are going to use this new drug. So already I have an idea that 40,000 people have an unmet need. That's what unmet need is. It's different disease. Once I have that data and I have an idea of the volume of the population, I'm going to say, okay, so in these 40,000 people, what is the product efficacy? Has this product been tested for those patients that don't respond to metformin? Yes, no. So I'm looking more in depth at the trial data. And I'm also going to see if the data is not in the trial, I will surely end up doing indirect comparisons. So what's really important here is that I'm going to establish that in my country, metformin was the right comparator. So even if the trial was against let's say, placebo, I am going to look at how this compares to what I already have. Why? Because I don't want to pay more for something that only brings this much to what I'm having. Maybe it brings this much, but I need to assess. So once I have an idea of the clinical benefit, I will have an idea of the comparative benefit. I will have an idea of how the clinical guidelines need to change, and if this product comes after metformin, and therefore I'm changing my guidelines. And I will also have an idea of expected volume. All of this data fits into the next function. Please click. So the next function will take all of that, all the clinical data or the comparative data, and at this point, they're going to bring in the cost. They're going to look at what budget impact is going to be at the estimated price. They're going to look at how much it costs currently just with metformin, how much it costs me, all the side effects that currently are not controlled by metformin, all of those situations where the patient did not respond. But I'm also going to look at things like how much will the management of the side effects of the new product going to cost me. So I'm going to put all of that into balance. That balance tends to take, like I said, different versions. It can be a very simple mathematical formula. This is all the direct and indirect costs in this treatment. This is how much it costs in this treatment. So I just compare maybe like for like. Potentially, I make it more complex. I bring in utility, quality of data, etc. It's less important. What's important is that I do have some idea of how the price related or the price requested by the manufacturer kind of will have the impact on what impact will have on my budget and how does it actually fit into the overall idea and scheme of the things. So once I have that, we create a very nice dossier, which is the health technology assessment dossier in many of the countries. And with all of that data, both clinical, economic, AP, burden of disease, unmet need, all of that systematically presented, I'm going to give it to the next team. Please click. The next team, which will have to do the negotiations, if it's for a new medicine, and it's something that they will need to, so they will bring in practically the conversation of cost of the additional value rather than just price demanded by the manufacturer. It gives us the capacity to say, you've requested this much. which is 40% over what my current treatment costs. But realistically, you're only bringing 20% of clinical benefit. So if I compare the two, can we agree that, you know, I'll give you a smaller population, you can only come after the other ones, but can you meet me halfway? So it's the type of product negotiations if it's a new molecule. However, if it's, for example, a generic, you are in luck because you're going to say, okay, so you're the same as everything else that I have on the market. So can we agree that the maximum price that you're going to have is the one that it's already the maximum on the market? So this is the type of discussion that needs to happen at this level. This unit will, or this function will also potentially issue things like decisions on how the reimbursement, on how this product should be used. So they will say, I'm giving you conditional approval to come into my list based on results, and I'm assuming the results are going to be there. Or I'm going to say, you're over, or I'm going to say you're a generic. By definition, as a generic, you should come as a cap of 65%, 70%, 60%, whatever you think. 60% is to be the average in Europe of how much the innovative drug is. So this is the unit. This function will issue pricing regulation. Moving on, click please. And then when we move into the next, once we have this, all of this data, this package of data will go to the health insurer or the vertical program if we have vertical programs. They will look at all the recommendations on how the clinical guidelines should change. They will look at what the maximum price should be, and then they will look at what the volume is going to be, and then they, with a guaranteed volume, they will try to issue a tender or have additional discounts. They're going to make volume or even portfolio negotiations. This is one of the tools that is very not used a lot in the countries. The US is very good at it. And then this function is going to say to the hospital, this is how you use it, to the pharmacist, this is how you release it. I'm going to this, so these are the conditions in which you can give it, and it can be given to those patients, and this is how the guidelines are going to be applied. The next function, please. Click. So with all of that data, and knowing exactly what is it that you need to monitor, the monitor function will come over and will take over, and is going to start and look at, so what is the actual real burden? We were estimating 40,000 initially for this patient. Is that, did we use it in 40,000 by the end of the year, or did we use it in 50,000? Did we have enough, if this new product was branded and, people like brands, and did we see that we're starting to see a prescribing that is a bit off? We're seeing used instead of metformin. Yes, no, what can we do about it? And they feedback that one to the health insurance who will need to modify and make sure that they come with tools, but they also need to give all of that data back to the regulatory to say, realistically, we should have another drug to compete. So for example, if here I'm just having one competitor, can you, if you receive an application from a competitor in this area, please prioritize them. So this is the type of information that would need to go back and feed back into the system. I think we're having quite a few questions coming through. So I don't know if you want to take a break here or I continue.
Yes, I think we have a couple of questions, and as you said, the slide was quite dense. So thanks a lot for this more in-depth presentation of the functions and how they interlink with each other, also going deeper into the data and the tools they would use. I think that was quite an intense overview, so maybe we just take a short break for the questions and then move on. So I'm not sure if I should read them to you, or can you follow?
I have a comment from, I think we are missing one key factor that affects most of the developing countries, the economic stability. These drugs are manufactured abroad, and if no stability in economy and forex, you will be designing packages yearly as providers will have to listen to you. Yes, that is true. Some of the packages do need to be updated, and that's a bit of a pain. But you don't have to do it all the time. But that being said, it's not uncommon, for example, for a country to say, for health system purposes, that my forex exchange rate is this, and you set it in ground for the next year so that it doesn't balance from one month to another. So that's one solution. So what I'm trying to say is that this pricing function has and should have a regulatory view of the system. In many of the countries, we're seeing that there is little, the countries or, the governments a bit hide away sometimes because it's such a visible function and because you don't want to upset the private sector when you're coming and you're saying, I'm going to say, these are my rules for the market, but that needs to happen. So when I'm seeing that type of situation, yes, but I'm not going to refer to a situation, unfortunately, like Syria. So I'm assuming that the country at least is stable and we're not in a war situation. But assuming it's one level up, from that point on, as a regulatory function, the government has the capacity to control what's happening, one, when coming into the market, but even issuing rules about how to exit the market. What we've seen in Togo, for example, is that the manufacturers are actually pressuring the country to accept certain prices just because, well, it's a small country, you're using the CFA, it's, you don't have the volumes, etc. But when we looked at the prices tend to be 2-3 times the price of Europe. And when I asked them why, and they said, well, we're not regulating in any form or shape. And I said, you can set a rule from the get-go. When you come into my country, the prices need to be at maximum and we establish something. Be it at least the basic international reference pricing, because again, what was happening in Togo was that I was seeing, Togo is a very small country. For those of you who don't know, it's in between Ghana and Benin, and in between. So genuinely, they have Burkina Faso. So genuinely, they have a lot of products coming in parallel trade from the other countries because they're actually cheaper. So people end up buying it out of pocket from the other countries. So all you have to do is say, if that price worked in Ghana, which is just across 10 kilometers, I'm sure you can give it to me too, because it's the same manufacturer. So, and you can have an agreement with Ghana. So I'm trying to say is that this pricing decision, it's quite heavy, I agree, but it needs to be a bit more thought through.
Yeah.
Okay.
So there was another question in French. Est-ce que le système de régulation inclut même la prescription des produits pharmaceutiques
yes,
par les cliniciens? Yeah, so
of course, it's absolutely mandatory. So any kind of guidelines will be by INN. The INN means that sometimes it's a new product, sometimes it's a generic, of course. And actually, just from a sustainability perspective, the more competition, so the more generics we have in the market, we are better off. That being said, it kind of, the added value stops at about 7 competitors in the market, but I think up till 7, we have a bit to go. So yes, this system does reflect also how we should be looking at generics, and actually the French do it. But what they are doing is that they put less emphasis on the scientific and the pharmacoeconomics team, and they put more emphasis on the tendering part. But they do look, is this equal to what I already have in the market? Yes, no. So it goes very, very fast through the other 3 functions. And then the pricing unit just says, okay, you're the same. Do you agree to have the same price or lower? I think we can continue, actually, because we were just talking about France, and because I'm wary of the time.
Yeah, definitely. Let's, we will pick up the other questions later on, but let's maybe move on a little bit with the concrete country examples, and then we will have maybe also a little bit of a better understanding what you mean by the tools and how they are applied.
And by the way, I just want to make sure that when I'm presenting these tools, all of you need to be aware that this is kind of like, I've tried to systematize them and I've tried them to streamline them. They're not the absolute ones. They're not the only ones. What I'm trying to say is that just look at how the information flows and make sure that the information is there. And then each country will adapt the tools based on their internal capacity. So let's click, please. So the French system, the reason for which I chose France is because, like I said, from the WHO perspective, it has one of the best health outcomes in the world, but also in terms of the deficit of the health system, it has one of the lowest in Europe. So from that perspective, it works very well, and it has definitely some of the lowest prices out there, and considerably lower than the US. So what do the French do? Well, if you're looking at what they're doing in terms of the regulatory team, the only thing where they are not doing right now is that they're still accepting placebo trial. And that has actually less to do with the French and has to do more with the European Medicines Agency. When they are issuing, they are still issuing only the product indication and the product safety. They're still not going further down to put it further into the populations. But there's a lot of talk between the regulatory function and the next function. So click, please. So the transparency committee works very much, which is the expert review team. It works very much hand in hand with by getting some of the data from ANSM. So they actually look, like we said, at everything from the unmet needs. They will establish the product population. They will even say, yes, the indication is this large, but we are going to go even further down because in the trial, we're only interested by a subpopulation of that situation, of that disease. And then at the end of it, they give a clinical benefit, a comparative benefit. They give an idea of the innovation. They have an innovation scale. And they even say, these are the expected volume of patients over the next few years. Click, please. The next, the pharmacoeconomics team intervenes mainly for the very expensive new products, so the new molecules, for the generics less, and they just leave it down to price. But that being said, the pharmacoeconomics team does look at more innovative products, and they are going to look at the expected volume of patients, hospitalization, cost of the comparator, and make a comparison. What they are not very good at yet is looking at the cost of the side effects and the cost of other costs which are not direct costs. That being said, I know that their economic team is putting quite a bit of effort behind it. So what they do have at the end will be an overall assessment. Yes, it should go, it should give the go ahead or not. The budget impact, it does less of a tariff impact. So what is the impact of not looking at the tariff? Well, let's put it like this. So you have a new product that comes in, and actually it decreases your hospitalization days by, instead of 10, you have 7, because your product is more efficient. So you don't change the tariff. You don't look at how the tariff is affected. So from that perspective, the hospital will have a bit of more leeway or more money to work with for potentially other situations. Or we have an overall inefficiency in the system because I can't guarantee that that money will go to something else. Or what's going to happen is that in order to receive the full money for the tariff, the patient will still be kept 10 days. Instead of 7, despite the medicine saying, curing the patient in 7. So these are the types of things that we need to start paying attention to. Moving on, please, next function. So what are they doing in terms of the pricing? Well, definitely they're not doing anything related to face-to-face negotiations. Definitely not doing anything related to portfolio of needs. However, this is the country that sets, by the way, the minimum price for Europe. It's the country that will look around. And if there's a country in Europe that already has the lowest price, they will say that that's my price too. But then, or at least the one in which I'm starting discussions. But then I'm also going to, if no other country has it, I'm going to establish it based on what's the price of the comparator. So the price of the comparator is actually one of the starting points in terms of discussions for price for a new product in France. At the end of it, they're going to have a price, and then they're also going to have inclusion in the reimbursement list, and they're going to say if they reimburse it 100% or 65%. Next one, please. Click. So in terms of purchasing, of course, the health insurance fund afterwards will make sure that the guidelines have been issued. They will do some negotiations. I wouldn't call them tenders, but contracts for 2 years, framework contracts for 2 years. And the tendering tends to be done specifically by the hospital in most of the cases. And then most of the times they will make some agreements based on the volume that we are expecting for the next 2 years. They will also then give very clear guidance to the hospitals and the tariffs and the product usage to make sure that the product is used accordingly and reimbursed. And then click, please. What happens in terms of monitoring is that they are looking at mainly volume of products. They are only looking for hospital usage in those hospitals which will dictate the tariff, the DRG tariffs. They don't do it, however, systematically, and most of the times they have. So as a result, their statistical data about the real world burden of the disease versus consumption data is actually quite skewed. So the regulatory agency, when they make decisions, most of the times they're not always sure on which kind of data to rely on. Should they rely on what's coming from a few hospitals? Should we rely it on the statistical unit of statistical institute of the country? So that's a bit of an issue there. So that's an example of a country. However, you can see that they pretty much do everything, and you can see that they've integrated quite well. So there's a clear pattern of how the information goes from one to another. If we look at the next country, please click. I'm sorry, I'm putting them just because they have been fantastic and working quite a bit, but Togo has been one of the countries that is just at the beginning of this reform. So click, please. As you can see, in terms of regulatory aspects, they still have to bring it up to speed. It's one of the countries where it's only one division, the Ministry of Health, and it's still quite theoretical. But they are trying to they're looking at least roughly at the safety and quality, and I think that that's a fact that needs to be enhanced. That being said, they give a marketing authorization, and they will say if the product is safe or not. Click, please. When it comes to, however, the clinical review, their clinicians and the big KOLs in the country, key opinion leaders, they have less data to rely on. So they mainly look at the indication, they mainly look at the trials, they have some idea of what the country uses in practice because it's a small country, so kind of know what your colleagues are doing, but it's kind of knowing. The guidelines are not really followed, they don't have an idea of what's happening, so the decision on whether this is better than what I'm having or not is most of the times purely taken on clinical trials rather than on real world evidence. Click, please. Unfortunately, there is no conversation about price. There is free pricing in Togo. Click, please. And that unfortunately also has a negative impact on the actual reimbursement decision. So the health fund is just put in a situation where they practically need to pretty much pay for everything. And they also, because there is no clear utilization in which population, etc., lines of treatment. So they are in that situation where they haven't been able to do much. So we're working with them right now at establishing maximum caps, and we are regulatory and some regulatory aspects, initial ones, at least for the health fund, and we're hoping that that is going to reflect on the overall pricing in the country. Click, please. Then on the purchasing side, like I said, the National Health Fund, which is mainly for the public sector, so it's still quite narrow, only at best is going to do some tendering at best, but that's mainly done by the hospitals. And then maybe they will lately, so finally for the past 2 years, they've started to look at the product usage, again, mainly within the hospital settings, but not within the tariff, not necessarily related to a disease. And they are starting to look actually also at what's happening in pharmacies, but it's very, very limited. Click, please. And then the last and then the last part, like I said, except for the product volumes, the monitoring doesn't really happen. So as a result, they also don't really have it happen. For the past 2 years, they started to do something, and actually right now they are setting up a new pricing methodology, which is based on the consumption data and what the patterns that we have seen. And also they are starting to review the drugs that they're already reimbursing based on this clinical and also economic impact. So at least the budget impact is starting already to be brought in the conversation. Okay, click, please. Just because I'm wary of the time and I would like to take more questions, and I'm sorry if I'm going too fast. This is the last slide. So I know I've emphasized it and I've overemphasized it, but it's one of the critical functions that unfortunately we need it if we want to make decisions based on data. So what we need is the monitoring. What we really need is to make sure that we are aware of the volumes of medicines used, of the spread of our diseases. We need to understand in reality what drives our mortality, but also what drives our costs. Because what I'm seeing again, a situation, unfortunately, of so Philippines was giving, finally they looked at what was driving the costs of the fund, and they discovered that it was about 10 diseases. And they were not necessarily they're high burden diseases. It was things like dialysis. So they called them the bleeders, and I completely understand them. And it was about the way that the package is done, and because they didn't monitor necessarily what was happening from the get-go, and they made the decision not so much related to the burden of disease, but just because it was a request to do a package around it. As you can see, then we ended up paying a lot for potentially a disease that takes a very small volume, and it's not necessarily my biggest issue. Another example of something like that is, for example, again, Togo, where 4% of their population has diabetes right now, which is not a lot, and it's fine for a country that is very young. However, it was taking up 16% of their budget. And the reason for which that happened is because they were not monitoring. And when we started to look at what's happening, it's not because they were reimbursing necessarily brands, but it was a fixed dose combination that was taking a quarter of that amount, one drug alone. And it was mainly because it was just one competitor in the market. So we either, go back to the drawing board and say, okay, if that FDC costs that much, we're going to just use the two generics separately, or we are going to try to negotiate and do something about it. But again, until you're looking to see what's happening and what drives your costs, you can't really make a decision and adjust your system to what's happening. Click, please. Click. Okay, so this is exactly what we said. In most countries, there's still a tendency to limit the type of data that we're monitoring about medicines because it scares us. They tend to be like in the 6,000 of them on one list, just the INNs, or if not the INNs, the overall with the brand names, and especially the generics. And with the generics, it's worth looking at because it's big volumes. And we are starting to look. We've been focusing so much on the big items, big ticket items in terms of price, and we're controlling that. We're getting better at controlling that, maybe it's the correct way of saying it, but we're starting to lose track of the millions of beta blockers that we're using. So potentially we need to look at what our prescribers are doing, and potentially we need to look at how they prescribe and to make sure that the INN prescribing is there. We make sure that the generic is there. So I'll give you an example, very well-known example. So in hospitals in France, because no one is looking at what happens with the off-patent generics, etc., is just under the tariff. What happens, and not just in France, most of the European countries, the branded team goes and gives the product almost at peanuts level. So it's very, very cheap. As a result, the physician starts, let's say, the hypertension treatment in the hospital with the branded product. That creates loyalty if they see even already in the patients, not to mention the physician loyalty, a different discussion. But that also then creates a situation where coming out of the hospital, the patient will want the same blue box. Or if they don't see the box, they know that it was, it was that INN, but I know it was, that product, it was that brand. So again, because we are not looking and potentially the patient is willing to pay out of pocket, we're not going to look at it. But that's just one example, and it's millions of them. So that would be kind of my, sorry, I'm aware of that.
No, it's very interesting, and I'm sure our audience is happy to hear more examples from you. But just to fit in the time of our valuable audience, let's maybe pause at this point. And so now we have seen very interesting examples of country systems with their applications of the various tools. And I guess the interesting bit is that, well, there were a lot of technicalities, but basically we can clearly point out how the framework can be applied to various settings and various levels of sophistication of a healthcare system. So I think you made it clear how you apply the framework very generically, and you can see basically where the gaps are and where potential improvements can be made with maybe little changes step by step to actually improve either the functions, one in itself, or actually the communication between the functions, such that we have higher efficiency, better control of overall cost, and actually manage our total budget, which we look at in terms of financial sustainability. So I think that came across very well. Let me ask you a very simple question before we go and look at the audience questions. What do you think? How would the framework or the application of the respective tools help us actually to bring down prices? Because what came already through the discussion is actually that, especially in low income and, well, developing low income or emerging economies, what we actually see is prices which are higher, double, triple the size of actually international reference pricing. So this is a continuous struggle, and this is a continuous struggle which is oftentimes addressed more on a level of advocacy almost, or of a level of accusing the pharmaceutical industry, which is accused of setting those prices. But we rarely see clear solutions to that issue. So what would you say, how can we address this practically?
Well, I think rather, so like I said, what happens in many countries is that the first response to that is a health technology assessment unit. The reality is that the health technology assessment unit will only evaluate one product at a time.
Does it help? Will it help?
It will help. It will help for certain products, for certain diseases, and especially for big, for high ticket items. And by that, I mean, you know, the very expensive ones. However, if we're looking, however, a bit at systems developed ones, and we're trying to see who manages the prices the best, where the biggest difference is US versus Europe. What is the big difference between US and Europe? The regulatory function. So the price in Europe, in all of the countries, is regulated at the point of entry. So even before I'm even making a decision as to whether I'm reimbursing you, so I'm including you into the formulary and I'm going to pay you, and at what price, which is going to be a negotiated price, I'm going to have what's called a public price. And that public price, most of the times, tends to be an international reference price. So the least that we do, at least in the European Union, is that we're going to see what the other countries are doing. It's basic stuff, but also because we have open borders, so you can imagine that the medicines are going to fly around. That is it. So the first thing that we do, we regulate. Not only do we regulate the price by looking at the international reference pricing for potentially products that are available across the borders, but we're also imposing limits on for example, what we call the caps on generics. So we are saying if the innovator price, when they came in, it was this much, you cannot come above a certain level. And by the way, that certain level is 30% in Greece, it's 60% in France, it's 70% in Bulgaria. So these are countries that not all, they intervene actively. It's not just pharma comes and says, you know, they set their price. What happens in the US where this function doesn't happen is that we're seeing that the health insurance funds, they struggle. And they struggle because they know that they need to cover it. So what happens is that they'll increase the premiums. If you want that drug covered too, you need to pay more. So like I said, it's also about taking a bit of an active role in it and making sure that you control it. What's also very important is that you don't just control the price at the point of entry for the manufacturer, but you're also very clear on the markups. What I've seen in many countries.
Exactly. So yeah.
Exactly. What we see in many countries is the distributor markup tends to represent 50% of the price. So if 50% was the manufacturer, they double the price. This cannot happen.
Within the country, then specifically.
Within the country, this cannot happen. You need to have a set rule. Whether you apply the same rule for everyone, or you say, okay, some of them are in just 3 places. So very narrow volumes, I'll give them a different markups versus high volumes. Either or. You need to look at what's happening in your market, but then you also need to set rules, because that is taking an active role rather than a passive role and just passing it to the pharma industry to take into consideration my affordability levels. Realistically, it's not going to happen. So it's a two-way. We can't just assume that the fact that I'm imposing on them the compulsory licensing is going to give the prices down. It's not.
So basically, two takeaway messages. One, national institutions, national players who are responsible for the respective function, namely pricing, can take a more active role in setting limits, setting caps, or negotiating the respective prices. And then secondly, also to regulate the internal markups and, well, basically all along the supply chain, actually. Exactly. Okay, there's one related question to this. So the question is, what would you say is the best reference that low and middle income countries could consult for international reference prices? So what would be the source or reference?
For reference prices, just so be aware, the best one would be publicly available one is French and Germany, France and Germany, but be aware that these are public prices. Even so, the public prices are still lower than what I found in most of sub-Saharan Africa. So I would use a country like France because Germany plays a lot on their volume. So a country like France or even Italy, both of them tend to have among the lower ones. If you want the lowest prices in Europe, www.ms.ro. So the Romanian system has the lowest prices in Europe, and public ones. So that would be the lowest that you can get. So at least you have an idea within the European Union what are the prices. So I would say if you're going to look at average prices for Europe, which still, like I said, are still the best control ones, would be France. If you want the lowest, are Romania and Greece.
Yeah. Okay, we have another question related to provider payment mechanisms. So it says, it's a comment, the level of technological advancement is also critical, which contributes to provider payment mechanisms and direct effect on benefit package design for ease of payment. From my many years of experience here in Nigeria, it's better to design packages that have the ICT capacity to monitor the payment. If not, expected beneficiaries will suffer denial and sometimes undersupply. So this is, I think, a classical situation as well once we look at bundled payments, which are supposed to cover the medical part. However, as we know, it does not always is the case. So any comments on that, on the linkage of drug prices and provider payment mechanisms, or let's say case-based payment, DRGs, or tariffs, which are supposed to cover the medicines included in that package?
So I've actually mentioned earlier that when even before the final price is set for the system, one needs to look what the impact within the tariff is going to be. So that's the first interaction point. But then again, talking about active role, the prescriber control, and this part where I was saying that the acquisition and the provider reimbursement needs to take an active control. You need to give to your health insurance funds or whoever the fund, you need to give them the capacity to control what their providers are doing. And by giving them the capacity, I mean, you need to give them or allow them to use the guidelines, almost kind of like in a mandatory form, and allow them to not reimburse a situation to one hospital and even say why publicly. The other thing that is very, very important about this framework and actually around the world is to empower your patients. They need to be aware of what those benefits are. And they need to be aware, campaigns, we know very well campaigns in which the generics are made less devilish because they are known to be, they're considered to be for quality, etc., etc. So campaigns in which we are explaining to our patients, there is a point in going and asking if there's a cheaper version. The part where if we find a physician that overprescribes brands, we actually go and fine him. These types of publicly, these are going to be things that are going to get the outcry of the population. I'm going to tell you point blank, it's going to, the medical association is going to jump. because they're going to say you're coming over my capacity to decide on which product I should be reimbursing or I should be covering or not. This has been the reaction around the world when it came to imposing the guidelines. The response, however, to that is we already had a clinical team formed by the big brains on this. We also had an economic team that looked at the capacity of this being viable. So these are our rules. We are doing this because we want to cover more people and we want to cover more drugs. And that's the answer. Because if you're going to go into clinical discussions with them, you'll never win.
Yep. One more question maybe, and then I'm afraid we have to wrap up. So the question says, you mentioned that multi-payer systems also do the various functions. Yes, all systems basically do the various functions. Each system does. Do insurance companies have to be a certain size before they can do this effectively? Can they even do if other insurance companies does not? How can private insurance companies collaborate with government to do this? So I guess we are looking at a fragmented system where we have different payers involved, public and private ones, but also multiple insurance funds. And actually, there's another question from Kenya, which is quite similar or going in a similar direction, saying, what is the potential role of the private insurance companies that seem to only follow what the providers set as their prices? The negotiations become very hard, and the national insurer doesn't seem very cooperative. So again, the split in private and public payers on the one hand, but also the private and public providers in the end, because private providers being more flexible or, setting their own rules.
Exactly.
Any comment on that?
Very quickly. First and foremost, do you need, how big the health insurance needs to be in order to start doing that? Not much. If you are able to get a physician on board, a pharmacist and an economist, just put them at the table. You don't have to do cost effectiveness analysis. You can still do a basic budget impact. What you need is some good estimates of within your plan, how many patients are likely to benefit from this and how many patients are likely to request this. So you calculate correctly and have an idea of the budget impact. The other thing about the providers, which set their own prices, again, comes down to your capacity to do contracts, which I know when you have a competitive market, they're going to say, well, I'm not going to work with you, I'm going to work with the other one. It comes down to bringing the physicians around by genuinely showing them that if we do this, we are able to also cover this. And this is actually trialed and tested in various countries where the providers, cardiologists, my favorite, they tend to kind of like go and do their own thing because, especially with the heart diseases or hypertension, we know that a patient is not going to respond the same to a brand and another brand, let's say. So they go and they do, and then only when they see the budget impact, and I'm showing them, look, if we want this sustainable and you want more patients and you want us to promote you to more patients, can we agree that you're going to give, this INN, you're going to prescribe INN, and also, by the way, I estimate this volume. I'm going to go and negotiate with the manufacturer directly. Can you agree that you just tell me how much it was and I'm going to work with the manufacturer directly in supplying and reimbursing him? So you may need to slightly adapt to what's happening, but you can do it.
Yeah, so again, it's a matter of cooperation and communication, and also using the stick and carrot approach maybe to certain providers.
Yeah. And don't be afraid to engage with the private sector, because many times I'm seeing the health insurer only working with the providers and almost never engaging with the actual supplier, as in the distributors and the pharma industry. I would start a conversation there, because especially in countries like Kenya, and we know this, and not only Kenya, many of the companies are struggling to get into the market because they can't just go negotiate with each provider. They would actually rather negotiate with you if you are able to provide a bigger volume of patients.
Right. I'm afraid, looking at the time and our schedule, we have to come to a closing for today. I believe, as far as I can see, that it was a great opportunity to start a global conversation on this topic, and we hope that it was useful and informative to all of you. This is directed at our participants. As for the next steps, I would like to mention that, so first of all the participants who registered will get a follow-up email from us with a link to the recording of the session, as well as a concept note, which will sum up the major points of today. So you can also recap on it. You can also pass it on to colleagues if you wish. Please feel free to share the resources. Be happy to share and engage more with the larger community. You will also receive a link to an online forum where we will post and reply to the remaining questions, which we could not address now due to the time constraint. You will also be able to post additional questions, and we will come back to you with some responses. So happy to engage there. Please join. You will receive the link. Finally, all the participants will receive a link to the evaluation questionnaire. And here, again, as I mentioned, we will suggest some options on how to possibly move ahead from here. So we would really appreciate you take some minutes to respond and give us your feedback. It's a quick multiple choice questionnaire. So based on this, we would propose the next activities to come if you're interested, if you think that's of value to you. Otherwise, I would like again to thank our speaker, Joanna Urso, today for the enlightening presentation of the very interesting innovative concept. And obviously to all of you for joining in, engaging here with us, posting your questions on your systems. I'm glad we made this happen, and I hope to see you all again in some occasion very soon. Wishing you a good day or night, depending on the continent, and see you soon. Goodbye.
Thank you very much.
Thank you. Thanks.